Welcome everyone, and thank you for your interest in attendance at the inaugural Global Digital Health Summit here at the Bloomberg School of Public Health. Sorry. We were inspired to organize this event after having the tremendous opportunity to volunteer at the Global Digital Health Forum in December of last year. The experience opened our eyes to the incredible potential of digital technologies to transform healthcare delivery and improve health outcomes around the world. This summit has been a collaborative effort across multiple student groups here at the school, with critical contributions from the core organizing team, which comprised of some of our colleagues here. Marcela Vanegas, Isis Gomez, Asil Saleh, Mohammed Paracha, and myself. The broader organizing committee spanned members from 6 student groups here at the school, which were the Digital Health Society, the Latino Public Health Network, the African Public Health Network, Anna Bejo Society, the Asia Pacific Public Health Network, and the J.B. Grant Global Health Society. None of this would have been possible without the tremendous support from the Center for Global Digital Health Innovation here at the Bloomberg School. The center not only gave us the chance to attend the December's forum, but also provided invaluable guidance and resources to make the summit a reality. We're also incredibly grateful to our partners, including our sponsors, the Student Assembly and the Office of Alumni Relations, as well as our collaborator, YODH, the Youth Ownership for Digital Health Initiative. We would like to thank everyone from the special events team here at the school for supporting us with the logistics for an event at this scale. Over the next 2 days, you'll hear from 20 leaders and experts driving digital health innovation globally. A few highlights include a keynote address by Marcelo D'Agostino from the Pan American Health Organization. We also have a panel on scaling digital health worldwide, which features representatives from organizations like the World Bank, PATH, and exploring strides made in digital health across Africa, Asia, and Latin America through the perspectives of the African CDC, the Asia eHealth Information Network, and RICANSA, which is the Central American Network of Health Informatics, as well as a chance to learn about forging careers in this dynamic field through our panel and 2 networking sessions. We hope you get the chance to engage in insightful discussions over these 2 days and delve into the world of digital health with us. It is now my great pleasure to introduce Dr. Smisha Agarwal, the Director for the Center for Global Digital Health here at the Bloomberg School, to provide some opening remarks.
Great. Welcome everyone to this session, and welcome everyone to this summit, which I think is just so exciting that the student groups have gotten together and organized this session. It's really, I should be honest that when the proposal was first made to me, my jaw dropped at what was being proposed. I'm moving. And so really huge congratulations to the organizing committee. Yeah, and we'll come back to the organizing committee after. So I was asked to provide some framing for digital health. I see some faces here who've been part of the courses that we've offered and have framing, but I wanted to quickly take you through some slides as we think about digital health, because often digital, especially in this environment, in the US environment, is thought of as apps. And I want to make sure that we are able to think about digital as beyond just that. So let's see. There is, first of all, and I state this enough, but the rationale for digital is not digital, right? We're talking about shiny tools with a lot of private sector interests, but really this is the starting point. It is that there is variability in coverage of universal healthcare. We see where the variability is in the adoption or availability of services globally. What this doesn't show is the variability in quality and health outcomes, right? And there is a lot of global variability in quality and health outcomes. There is a changing trend in how we think about healthcare. So for example, over here we see that there is rapid increase in healthcare spending. Healthcare spending is growing faster as a percentage of GDP. And there's also a global shortage of over 10 million healthcare workers worldwide, a lot of it concentrated in certain regions like sub-Saharan Africa. There is also this other transition where life expectancy is increasing, but also the average number of years that we live with illness is increasing. And that's a concern in several regions of the world, where the duration over which individuals live with substantial illness, ill health, is increasing. And this isn't just the case in the US, it's also the case in other parts of the world. And then finally, there is this opportunity where there is a rapid increase, and this graph shows not just rapid increase in mobile phone use, it shows mobile internet services. Mobile phone use is near ubiquitous, but also mobile internet services, you see, is approaching 50% of the population. On the right-hand side, you see a graph which shows that when individuals are asked, and this is in 6 sub-Saharan African countries, when individuals are asked about whether they used, what they used internet services for in the past 12 months, most of them said that they used it to access healthcare services on their phone, or healthcare information on their phone. So what, again, is changing is how individuals use healthcare, how individuals access healthcare services. So this really is a confluence of a changing trend in healthcare opportunities, and then consumer behaviors, patterns, and epidemiological transition to the types of conditions we are experiencing as a population that really opens up opportunity for digitization. Now this is an old, about a decade old paper that really focuses on what are the digital opportunities. And this says mHealth, but I'll say digital, and that's maybe the change in terminology over the last decade, where we are thinking about digital much more broadly, more than just mobile use. And what this shows, this is based on the Tanahashi model, and what this shows is that as a first determinant layer to achieve universal health coverage, we need to understand who's our population. We need to be able to enumerate and access our population. And at each level, we can't actually access our population or enumerate for lack of, for example, a unique identifier or enumeration of the population. As we go up, we may have limitations in supply of health facilities. I think I already spoke about availability of human resources, commodities, and then there may be lack of availability of demand, quality, and cost. And there are digital strategies that along each of these gaps might be able to address some of the gaps to improve service coverage, to improve quality, to improve productivity, and improve efficiency. So here's how, this framing of how we think about digitization is old, but I think it still rings true. It's one of the fundamental framings in my mind, is there are digital interventions that are targeted towards clients. And in the US ecosystem, we often think about that. I think especially within student groups, we're always mostly interested in apps that can, that can change some kind of health behavior. There is another sort of way of thinking about it, interventions that are targeted at providers. That's the bulk of our work at the center, at providers and health systems, where we think about how can we improve quality of care, how can we improve task shifting to actually address the problem of dearth of human resources, or having the right people in the right place at the right time with the right skills, right? That's the issue we're trying to solve for. And then how can we strengthen health systems or data services? And we'll talk much more about data, because the spectrum of digital is growing, and it's going from digital to AI. And so really, data is sort of that common thread that connects across health systems and facilitates AI. So this graph is something that was developed, I think, in 2014 by colleagues at UNICEF. And over the last 2 decades, what we've seen is a rapid proliferation of small-scale digital interventions across countries. This is a map of Uganda. And so you see here, the red dots are the number of different digital interventions. And what we've seen over the last decade is that these interventions have failed to scale and have the desired quality. The reason for that is that there is a lack of foundational architecture, there's insufficient governance, there's lack of integration within health systems, and poor design. And I think this graph here really addresses some of the issues that must be addressed so that we don't have the situation of extreme fragmentation. So one other way in which I can describe fragmentation is you go to your primary healthcare provider, they ask you to open up a record. Then you go to a specialist, they ask you to open up a different type of record and the data doesn't connect. You go to a third type of specialist, and so that's one example of fragmentation that I think all of us can relate to and have experienced in our healthcare journeys. And so that's maybe a similar sort of approach of like why these aspects, these building blocks of governance, services, standards and interoperability, having infrastructure, legislation, and so on, are critical. And so really, over the last decade, the most fundamental shift we have seen is from a conversation of digital that's focused on point-of-care applications or point-of-care systems to digital transformations at the national level in countries. And as a center, much of our focus has also shifted. We still innovate at point of care, but we also work very closely with governments, very closely with development agencies to say, how can we inform this transformation at the national level? So here's, over the last decade, and actually this graph only goes to 2015, but over COVID, we've seen the most significant shift. And what we see here is the number of countries that have a strategy for health information systems, for e-health and for telehealth, have increased. And in the last, I think, since 2015, so that's still the last decade, it's over 100 countries that have an informed digital health strategy. I think that's really important to know because what that means is digital is becoming core to how healthcare and health services are delivered. And I think we also see this in our student body here, where everyone is interested in digital. Chances are in your future, in your lifetime as public health professionals and leaders, you will at minimum have to be conversant in what digitization is, right? And so, because you cannot escape it. So there's this strategy, and this is the WHO Global Strategy on Digital Health to summarize, and Marcelo will talk about the PAHO strategy, which on digital health as well. But this identifies, again, in support of the country's vision of their own digital health strategies, 4 areas of growth and development. So one is to promote collaboration, so that digital health is prioritized and integrated within healthcare systems. That identifying that a lot of innovations in digital are actually coming from non-health sectors, right? It's coming from finance sector. It's coming from like building a national identity system, so other public systems that's accelerating digitization of healthcare services. Moving on to how can we support countries to implement their digital health strategies, recognizing that there is no one-size-fits-all, that it must be contextualized to the context, to the health situation, and the resources available. And I think we often miss that, but a country that doesn't have network connectivity or that doesn't have basic infrastructure in place may not be the right place. Digital can circumvent and leapfrog certain challenges, but there has to be some basic infrastructure, for digital to circumvent those challenges. Strengthen governance for digital health, and I think as we increasingly talk about AI, this is probably one of the most critical factors to actually start defining what security, privacy, ethical data use, data sharing looks like. There should be robust governance structures, including regulatory frameworks, and the capacity to build, to implement evidence-based implementations. And then finally, the purpose of all this is to have people-centered healthcare, and I think that's at the core of services. And we talk about this often. Digital, brings together different multidisciplinary stakeholders, including technologists, and each of us approach digitization so differently. Technologists focus on the technology, but often the technology may not be people-centered, right? And so that's at the heart of it. With that, there is a lot of hope and excitement and enthusiasm about digital. These are, I wanted to briefly go over the summary of evidence. What do we know about the impact of digitization in different contexts? And so here's a summary. We talk about, and this was done in 2020, and several faculty from Hopkins were engaged in building these guidelines with colleagues at the WHO. And so what we see is across a range of digital interventions. Here we see birth notification, death notification, stock management, client to provider telemedicine, provider to provider telemedicine. We see no effect from an evidence standpoint, right? So, and where we do see effect, we see there's very low confidence in our ability to say that actually digitizing it is going to yield a health outcome. When we go down to targeted client communication, so these are SMS-type interventions where clients may receive SMS messages or USSD channels for communication with clients. We see some effects on knowledge and on health behaviors of individuals. And then finally, for decision support tools, we see some positive effect, but a lot of no effect. And I think in general, there is a trend here. And I say this just to caution us, not to kill the enthusiasm and hope that we feel. It's just to say that digitization is appropriate in certain contexts. The evidence is still growing. It's a nascent, we're 20 years old, but from an evidence standpoint, we're still fairly nascent. And we do want to, we acknowledge that a lot of the digital interventions are complex health systems-wide interventions, which are difficult to study, they're difficult to measure. They're also very expensive, and they should not be taken as of course it must happen. I think there is a valid sort of argument to be made there, where it's like, should it happen? When should it happen? How should it happen? How should digitization happen, right? And so this is just to encourage us to pause and ask those meaningful questions. Because just because there's an app doesn't mean somebody will use it. If they use it, doesn't mean they'll use it consistently. And if they use it consistently, doesn't mean they'll have the desired health impact. So because health is not a function of just user behaviors, it's supply side. Several other factors must come together to actually have a health impact. So that's, and then I think the one point here is that evidence of no impact was often rooted in poor implementation and poor fidelity of the intervention. And so I think a lot of our public health training of how do we implement programs effectively is really valuable when we think about digitization as well. With that, what does the future with connected and coordinated healthcare looks like? And so if we are starting with, again, patients or clients at the center, this sort of pipeline is really a pipeline of data, and that shows sort of who's in the ecosystem of digitization, right? So there's a primary healthcare provider with optimized workflow. They're able to share your data and your healthcare information with specialists and hospitals. Decision makers at the government level are able to access disaggregated, de-identified data for decision making. There are adequate regulations around it. There are ways to connect providers to insurers so that services can be compensated. There is new advancements happening along the pharma value chain, and so on. Also, continuing on with this thread of data, there's the emergence of AI as an area with a lot of potential and also a lot of reason for caution. And so for patients' care journey through AI, or what are some use cases for AI, is at the population level, we have AI-enabled predictive analytics. We can advance how we think about preclinical and clinical research with AI tools. The last three areas where our center focuses on is how can we improve patients' clinical care pathways, improve diagnosis and prognosis of patients using clinical data. How can we improve patient-facing solutions? So that's the world of chatbots, therapeutics, personalized medicine, and then optimization of health operations. And so this is really, actually, optimization of health operations can draw a lot from what is already existing in other sectors in logistics management and so on. I might skip over this and briefly talk about what we do at the center, and hand over time to Marcelo. So our center is really set up to generate knowledge, to advance health equity through interdisciplinary collaboration and context-appropriate digitization. We say context-appropriate because we are not digital advocates. We don't advocate that you digitize healthcare systems without an understanding of the context. And that happens a lot more than you would imagine. We focus on three areas of research, innovation, education, training, and policy and practice. Within research and innovation, the sort of core activities are focused around data analytics and AI, survey methodologies. So Dr. Dustin Gibson here is leading a lot of thinking on survey methodologies. How can we use advanced ways of phone surveys, web-based surveys to improve our survey methods, to measure population health? monitoring and evaluation, where we are conducting large-scale effectiveness studies of interventions in the wild, innovation and design, and so this is really working with biomedical engineering to see how can we innovate and solve for some of the challenges in the healthcare sector, and then ethics and regulatory affairs, where we're thinking about how do we make this ecosystem safer. And I can give you a little bit of like what all of this language and jargon means practically. So for example, in Burkina Faso, a clinical decision support tool that's intended to improve the quality of prenatal, antenatal care services. We worked with the ministry in Burkina and Thérèse Déoms to understand how does clinical decision support improve ANC services, and conducted an effectiveness evaluation. We also worked with the ministry to improve the quality of healthcare data. That was captured in their DHIS2 system. In collaboration with a number of partners, including IBM, Meta, Bloomberg, Johnson & Johnson, Nacho in the US. And this is pre-ChatGPT. We developed a chatbot that was powered by natural language processing, focused on COVID-19 information. It was adopted by 12 states, health departments across 12 states in the US. This was a non-generative chatbot. That means it used NLP to understand natural language processing, to understand free text, but the response was expert vetted. It was non-generative. And just a note of caution is that when ChatGPT came in and people became aware about generative AI, there was a lot of fear that this is going to spit out responses that might be biased. And so even though the bot was non-generative, there was loss of confidence in it. Data for Health, which Dustin Gibson leads at Hopkins, and it really looks at advancing survey methodologies using mobile phone surveys is another example. We think about gender and how can we be sort of gender sensitive in how we are conducting population-based surveys, and equity sensitive. And then over the years, this is over the last decade, we've worked with a number of normative agencies to develop guidelines to think about what is the evidence on digitization, how do we measure the evidence, how do we scale digital interventions, and so on. Our team is in the process of working with 5 countries, Brazil, Ghana, Rwanda, India, and Finland, to study retrospectively what their digital transformation journey has looked like, and to facilitate co-learning between countries. Several students here, ISIS, I don't see other faces, GM now are involved with this initiative, and Shivani Pandya and Lena Khan. I'm pointing it out so that in your networking sessions, you'll connect with these folks, are engaged with this work. But it's really a wonderful opportunity to go in depth, study interventions, understand how governments are rolling these interventions out at scale, and learn from them. The WHO Digital Health Clearinghouse, we're supporting them to think about how do we use a framework to assess the quality of digital products, and what kind of recommendations can we make to governments that are looking for digital products that should be that can be leveraged in country. We also offer a series of digital health courses. There is a digital health certificate. There are 3rd and 4th term courses, summer institute courses that several folks are taking, as well as a number of Coursera courses that are planned in at least 3 languages later this year. So I think this is the details about the certificate and a little barcode for those who are interested. And I think that's maybe, and with that, I will open this summit. And if we can please have the core team, the organizing committee, please stand up and give them a big round of applause for bringing this all together. Yeah, thank you for dreaming big. So I will wrap up, and Katya, do you want to?
So Thank you again, Dr. Agarwal. And I'm happy to invite Dr. D'Agostino to the stage. So Dr. D'Agostino is the Chief of Information Systems and Digital Health in the Department of Evidence and Intelligence for Action in Health of the Pan American Health Organization, which is the regional office of WHO to the Americas. He's a systems analyst from Argentina with a master in information and knowledge management. And since 2000, Marcelo has held various technical and managerial positions at PAHO. He has lived in Brazil and moved to Washington. And he has played a lot of roles since, for example, Senior Advisor for Knowledge Management, Director of Knowledge Management and Communications, Director of Bioethics and Research, Chief of the Regional Office Library, and recently has led and implemented a renewed action framework for health information systems, currently leading the development of the framework of digital transformation of the health sector in Americas. Marcelo is the PAHO focal point to the WHO for the implementation of the Global Digital Health Strategy that's Dr. Agarwal just mentioned. So welcome, Marcelo. We have a microphone here. You want to use this one? That's great. Thank you very much. Yes.
Thank you. Thank you very much. So thank you very much, Smija, for the invitation. Muito obrigado, Isis, por el apoyo, por el soporte. Marcela, so happy to be here. For me, it's an honor. I always, when I was younger, let's say, I was always dreaming when being in my country or when I live in Brazil, and every time that there was a conference organized by Johns Hopkins, I wonder, wow, this is amazing. So, and today I'm here, so I'm very happy and very honored to be here. So thank you for the introduction. My presentation will be very practical, and I would love also to hear from you. I put some points for reflection. It is related on what we do at the Pan American Health Organization, but it's based also on real activities that we call technical cooperation. It's when we go to countries and we work with local communities, or when we have discussions at primary care level. So I want to see if then we can have a conversation on that. Let me start with the question. If you can raise your hand, how many of you knows exactly what the Pan American Health Organization is and what's the difference with the World Health Organization? 1, 2, 3. Normally nobody knows. So we are the oldest international public health organization from the system, the UN system. PAHO started in 1902 and then became the regional office for the Americas of the World Health Organization, when the World Health Organization was created as part of the United Nations systems. We work for the Americas. We are WHO also, but we are part of the Inter-American systems that is led by the Organization of American States. So that means that we have our own constitution also. We have our own legal constitution, but we are always engaged with global initiatives, and we are representing the World Health Organization. So thank you very much also to Professor Alan Labrick, because he suggested my name also to be here. I don't know if he's connected, but thank you very much. So we work, we have offices in 35, we call member state. We have a lot of terminology. Member state are the countries that are the one who can vote. Every time that we pass resolutions, they vote also for the election of the director. But also we cover 51 countries and territories all across the continent. We cover all the territories. We have French territories, we have territories from the Netherlands, we have UK overseas territories in the Caribbean. So we work with all of them. It's the only international organization who covers all the countries and territories in the Americas. Once a year, we have all the ministers of health. They are coming to Washington and they discuss high-level priorities. So, for example, the high-level priority was several years ago to work on a regional strategy for universal access to health and universal health coverage. Then we have strategies for NCDs. And we have, of course, a regional roadmap that was approved by all of them for the digital transformation of the health sector in the Americas. We work officially in 4 languages, Spanish, English, Portuguese, and French, but we also try more and more, in particular with the concept of leaving no one behind with indigenous communities and local language. So we are making an additional effort, in particular now that we are trying to implement telehealth initiatives in the Amazonas borders. So we need to be ready because we have some lessons in where we try to implement telehealth solution, but we fail because of language barriers. So an initial reflection that I want to share is related to innovation. Now, this is a real situation. The lady is the permanent secretary of the government of the British Virgin Islands, and together with her is the chief medical officer, former chief medical officer there. And they came in 2017, almost 7 years ago, with the idea of positioning the health sector within e-government initiatives. So right now seems to be a very obvious action, but this was 7 years ago. So sometimes we need to look at where innovation starts, and then we can see where we can do the implementation. But that was a lesson that for us, because we never imagined that we were called for a discussion 7 years ago on how to position the health sector within e-government initiative. This is why I put. But then when preparing for the presentation, and now, as Misha says, about AI, I asked one of the GPTs, the image generator, to create images about a digitally transformed health facility. And this is what we got. But the reality is, this is what is happening at the primary health level in the majority of the country. It doesn't matter if it's a big country or so-called well-advanced country or not. This is the reality. This is our team making a visit in one of the countries, trying to support them in order to pass to the process of digital transformation. So if we approach them with this vision, we will fail because this is unrealistic. So we discussed with them, they are still having issues with normative instrument because the key point is that everybody understands that everything can be digitalized with technology. This is nothing new now. But the problem is that if it's not supported by normative instrument, for example, you will see here, we have medical records in paper and a lot of computers. So my question was, why you have paper if you already have all the medical records on the systems? And the answer was very simple, but very powerful, because they didn't manage to change the law. And according to the law, they need to have everything in paper, and somebody needs to sign that. So they put a big effort. They have everything digital, but they didn't manage to change the law. So, and sometimes we fail when we provide advice to them, because we go there and say there is a magic EHR platform, or as Misha mentioned, apps and magical solution. We have 1,000 providers every week calling us, offering solutions, but we need to have a more holistic approach. And this is why I love public health also, because we need to have this holistic approach. We need to understand the context, cultural barriers, languages, etc. And in this case, is related to normative instruments. They have everything. This is also one person showing us what is going on digital platform, but also we go there to take notes about main challenges that they have in particular, and that is part of a reflection that I want to share with you that is related to change management. Sometimes we don't go with that approach when we start a digital transformation project or any project related to public health. We need to incorporate new elements like change management, strategic communication for behavioral change, etc. So where are we now? This is the result of activities that we do at PAHO. And when I say at PAHO, we collaborate with a lot of partners. but also it's the result of collective actions that we do with the countries. We try to implement everything together, hand in hand with the countries, because if not, it's just people from Washington with very nice theoretical documents that are not very easy to be implemented. So we discuss everything with them: vision, mandates, we have frameworks, we have a context, networks, and tools. So the vision, we are very fortunate today. We have a director, Dr. Jarbas Barbosa da Silva. He's from Brazil. He is a former assistant director at PAHO, and he's a former also president of the Anvisa, the National Agency for Health Surveillance in Brazil. It's like the FDA for Brazil, and is very respected and is very, very convinced about the digital transformation, the power of the digital transformation, in particular always for primary healthcare. But also we have a very high-level vision from WHO Director General, Dr. Tedros, including also from the Secretary General of the United Nations. I don't know if you saw the document, but he launched a very interesting document during the pandemic that when he defined that this is the age of digital interdependence, and the Secretary General launched a roadmap for digital cooperation. And then more and more what we see, our director always have conversations with heads of states and presidents, including if you read the declaration of the Summit of the Americas, including President Biden mentioned the importance of the digital transformation of the health sector and the digital transformation. So the vision is there, high-level vision is there. Then we have this technical vision. It's not for reading, but what we did was, and again, innovation that came from a very, very small country. In this case was Dominica, one of the small territories in the Americas. His position was ambassador at large, mentioned, why don't call it information systems for health instead of health information system? And at that time was like a semantic situation, but then during the pandemic was very clear, and that suggestion was in 2015, so 9 years ago. He mentioned you will need data from different sectors, not only from the health sector. And that was very clear during the pandemic, that data was needed from different sectors, and that this information system is bigger than public health or health-related data sources. No? I don't know if you are familiar, but for example, data from mortality data, that is one of the most powerful data sources for health systems and decisions, is not under the administrative authority of the ministries of health. It's normally part of finance, it's normally part of a national statistic division. So this is why we call information systems for health. And we develop a holistic approach for having a technical vision organized in 4 different areas. Is what just mentions Misha. It's not just technologies. We focus on data management and technologies, of course, because after 30 years of working on this, I heard a lot that technology is not the most important part, but then it's the first decision that countries make. Because people love to have a new software in place or a new app, but then there is a gap between the speech and the reality. So we put that because everything we do, we try to be realistic. But then we added an element of management and governance. So we discussed governance issues, financial resources, human resources, health-related legislation, data sharing agreements, etc. Then we have the element that is very connected with the academia, that is knowledge management and sharing. And we have an element on innovation that basically we focus on digital health per se, but also on how to connect the digital health initiatives within e-government initiative. And here the reason, and I want also to put a real case example, is that countries did a lot of mistakes when defining standards. For example, we had a discussion with the prime minister of one country that she was very upset because there was the Congress was ready to pass a legislation for a unique identifier for citizens. The health sector was working on a unique identifier for patients, but inside the Ministry of Health, there was a group on HIV working on unique identifier for HIV patients. So it was a disaster at the end because all of them did a big investment, all of them having conversation, but at the level of e-government, they were passing a national law on a unique identification for citizens. So this is why we insist with this concept now to connect, and we have a very interesting experience in Uruguay. Uruguay had the vision almost 22 years ago. They created what they call the National Agency for the Information Society. At that time, everybody was thinking that they were crazy. They decided an initiative they called Salud.ui, in where they define at the level of the head of state all the standards that are needed for the health sector. And today, Uruguay was one of the most advanced countries in regards to the digital health response during the pandemic. Together with that, we developed with the countries guiding principles, no? Because we always try to have some conceptual elements. We put 8 guiding principles that countries agree to follow for implementing national strategies and agendas, but also, in particular, with the Inter-American Development Bank, that they already invested hundreds and hundreds of millions in loans in countries on digital health. We agree to organize everything according to 8 principles. One is universal connectivity for the health sector by 2030. Then the idea of having and the co-creation of digital public goods so countries can benefit from different platforms. Small countries with 40,000 people are investing more than $20 or $22 million from an EHR platform, from one hospital, for example. So we are talking here on big numbers. So we are working with the concept of the co-creation of digital public goods, then with the concept of an inclusive digital health, looking at equity, interoperability, that is a word that more and more we are seeing in every single speech. Then I have a reflection on interoperability, human rights, mainstreaming everywhere on the digital transformation, artificial intelligence, which is some kind of the fashion topic today on any conversation, and we are having conversations. We may have an agreement with OpenAI to see if we can contextualize the use of OpenAI in public health, but also information security, which is one of the big challenges that countries are facing today. We have countries in the Americas that have more than 1 year under hacking. The entire government is hacked, and they cannot control that situation. We have situations with more than 400 million of records that were hacked, ransomwares everywhere, etc. So those are the principles. Then mandates, as Misha already mentioned, we have the global strategy. It's like the global guiding document. And then the one that you see on the right is that the roadmap that I mentioned, the roadmap for the digital transformation of the health sector in the Americas. This is a policy document. That means that countries, we develop the proposal once they have the discussions among the ministers of health and they approve. That is a mandate that we have to be implemented. So right now, we have this mandate and we need to support all the countries and territories in the Americas to have their own roadmap for the digital transformation of the health sector. I will not go into details. We did a maturity assessment. This is the first time in the region of the Americas that we can apply standardized tools to measure the level of maturity of all the countries in all those areas. So we know what is going on in different regions. And we try to avoid names, but we have 5 sub-regions. And so we know exactly what is going on data governance, data sources, information products, but also financial resources allocated or not, leadership, legislation, etc. So I will not go into the elements, but you have here the maturity assessment that is organized according to the framework that I explained before. These are some of the partners, and this is the only way to support countries today, because every single day we are discovering one partner or one international organization or an NGO working in a country and offering, in particular, EHR platforms. Some of them are okay and are based on international standards. Some of them are proprietary solutions. Right now, we are supporting one country because they made a big investment, but they didn't realize that the system was completely closed. So every time they need to connect that to a primary care facility who is running an open source solution, they need to pay to the provider and pay a big money. So what we are trying to do, and this is part of the convening power of international organization, in this case PAHO, but WHO of course, is to bring everybody on the table and to have all the key partners working together under a common framework and a common vision. You can see here, we have IDB, we have the World Bank, CDC, USAID, UNICEF. We have financial contributions from the Spanish Agency for International Cooperation, the German agency, Bloomberg, Robert Wood Johnson Foundation, etc. And all of them have different angles. For example, in the case of the Robert Wood Johnson Foundation, they want to support all discussions related to digital health and information systems that are focused on equity. But then we have CDC that they want to focus on epidemiological surveillance. So we try to manage all of them. So we have a lot of resources. I highlight only one, that is because we were happily surprised that we launched a training course on telehealth for primary healthcare with the simulation model. We did that in collaboration with the Association of Schools and Programs of Public Health here in the US. And in less than 1 month, we have more than 50,000 students with 35,000 with certifications. So then you can go over also the QR code. We have more than 50 products that are part of the digital transformation toolkit that we have at PAHO, but that they have also resources from other partners that are part of the network that we have. So where we want to be, again, with the image generator, I asked the GPT to what's the vision, the dream of a primary care facility in the Amazonas, no? So this is some kind of a dream. But it's also a reality, because we are very happy working under the leadership of the government of Brazil, in particular under the Vice Minister of Digital Information and Digital Health, Dr. Anastela Haddad, who is running a big initiative to have a telehealth solution across the Amazonas, in particular in indigenous communities. And President Lula was 2 months ago making the announcement over there to implement telehealth solutions. So, but also, and part of the reflection is where we want to be. I put here, I don't know, I am sure, no, if you're in public health, that you are familiar with the Alma Ata Declaration that was on primary health care, and then there was the declaration of Astana. And for me, what surprised me, and it's part of the reflection and the message that I want to pass also here, is that we need to be ready to embrace innovations and new things. This was in 2018, 160 heads of states agree on 4 priorities. Priority number 4 was digital health. But only during the pandemic, people realized on the importance of digital health. But that declaration was there 3 years before, or 4 years before the pandemic. So we need to make a self-reflection on that, because particular on digital health, for example, in PAHO, we launched the first e-health strategy in the world was in 2008, and was just an additional document that was there. And now everybody wants to implement something digital. But the concept, for example, concept of telehealth, they exist more than 20 years. How is possible that majority of the countries in the world, they don't have legislation that supports telehealth, if we have technology for more than 3 decades available for telehealth? So this is the part of analysis that we need to do in order to keep that in a sustainable way, and not to wait for another pandemic to see, oh, that is so important to have telehealth. And of course, our director vision is to have an innovative and more efficient strategy to recover better from the pandemic, and digital transformation will play a key role here. We have a combination of models today, traditional models of care and digital models of care, so we need to find a way to have one model that combines and to position the health sector within the e-government initiatives. So how to get there. This is a discussion, this photo is a discussion in Dominica with a group of public health workers there from different institutions. And these are photos that we took in our visits, no? On pharmacies, on different places, in different countries. The key point here is on how to get there. And if you can forget a little bit the part of digital. We need to understand the need of each socio-cultural context there. It's not the same project that we can implement everywhere. It doesn't matter if you have the perfect platform. If you don't follow the context and the needs that they have, you will fail. For example, in one of the countries, they told us, we need to know how to connect the police department here in a primary care facility. They said, why? Because we don't have ambulances. They are the ones who transport the patients to the hospital, and they need to have the data if something happening in the route. So those are the type of situations that we need to understand, because they are not written anywhere. You will not learn that in the university. It is not written in any paper on earth. The only thing is to understand the local context. Always focusing on the goal of what Misha mentioned about universal access to health. We insist in the concept of having more resilient health systems that are grounded in primary health care. Of course, we need to modernize public policies, frameworks, what I mentioned before. We need to participate in the co-creation of digital public goods. Open platforms are there. It's up to us to make a contribution, so we don't need an invitation to improve an open medical record platform. If we have the ability, we can make contributions always. So this is a part of the spirit also of public health as a collaborative network. And then, of course, we insist with the concept of digital literacy as a continuous program. So I admire, for example, my colleagues who works on NCDs. Right now, I envy them that they put healthy habits and healthy foods on the primary schools. We need to do the same, because it's the only way that then people will know how to proceed in addition what the UN Secretary General called the age of digital interdependence. Today, we need to wait until we have a degree in order to decide if we want to have a particular training on digital something. We need to put that on primary school, secondary school, everywhere, because the world will be digital. And it's the only way we change the culture from early education. So some final reflections here. We need to understand the new reality. This is a survey that was made in Europe about e-health priorities that were requested for, I can't remember how many people participated here, almost 300 people. And the surprise was that although they were public health experts, the priority number one was IT security. But for me, the most important one is number three, the system usability. And something that I learned, and I use a lot that example, is during the pandemic, my mother is 85 and lives alone in Argentina. No? So when started the pandemic, I was calling her every 5 minutes, don't stay at home, don't go to the supermarket, don't go to the bank. And she told me, I need to go to the bank because to do online banking, according to the system, I need to go to the bank and print the password. So there was a discussion then between the developers of the ATM software with public health experts. That never happened in life. So this is the type of situation that we need to understand, that maybe in the future, a software that will be installed on an ATM will impact or can be against a public health measure. So this is very difficult to think, but we need to start thinking on how to incorporate those situations. And you can see here, the first three elements are not, well, EMR implementation, yes, but IT security, system usability, and data exchange were identified by public health as priorities. The other thing is that some people are mad with this slide. I hope you are not, but I always tell, we need to learn from other sectors. We believe that we can solve everything. If for 1 second you think that what you have in your bank, instead of your money, are your medical records, we already solved the problem of interoperability, cross-border interoperability. There is no problem with unique identifiers. So all the discussions that we are still having in public health, the banking system solved more than 20 years ago. So we need to learn from other sectors. And now it's a very interesting experience in Indonesia, because the current Minister of Health is the former Minister of Finance, and is trying to bring all the system from the financial system to the health sector with this logic. The other point is sometimes we will not solve the problem. This is a famous equipment that for the people who travel, we use that a lot, that on how to connect my computer if I am in Brazil, that they have 6 different layers. Then you have here in the US, and then you have the UK. So we will never manage to change the entire system. So we go with the concept of, in health we call interoperability hub. So there are solutions already that we need to look again from other sectors. And these are just examples as a metaphor, no? And then for me, on the car industry, there are 2 that for me are iconic examples. One is the traffic light. I don't know when I learned that red was to stop and green was to follow, but I know that I know that. And everybody knows that, so you don't need to be taught that. You know that this is red, you cannot go. And this is because of international standards. It's the same thing that when you see a car anywhere in the planet with a white light on the back, you know that it's coming in reverse. These are international standards. They don't speak with each other every time that they develop a new car. They know that this is an international agreed standard. So this is the part that we need to incorporate in public health, instead of still having conversation on what are the international standards, how to achieve interoperability. We have 30 years having this conversation. So one of the recommendations is to learn from other sectors. The other thing is to learn from the past. This is a still valid statement that the most underutilized resource, as Misha mentioned, you go to one physician, you need to create your record, and you need to a specialist, you need to create another record, another record, another record, because we never involve the patients in discussions for software development or application development or for strategy development. That person mentioned that in 1970s. It's still valid. And this one talking on artificial intelligence, the same discussion that happened in 1968, we are having the same discussion now. So we are not learning from the past. And we believe that we need to learn from the past. We need to explore a little bit more about implementations. I need to confess, I am surprised when people say telehealth is something new or AI is something new. My degree at the university, my first thesis was on artificial intelligence 30 years ago. So there is a cycle on technologies, on new kind of fashion topics that are in place. So we need to learn from the past. And the final one is that I do believe that we need to manage the way on everything we do on digital transformation is to move from this concept that was clearly established across the world during the pandemic to stay connected at home. That means a lot. That means that we will have not only access to health services, but if you look at some research studies, there were a lot of problems about families having only one computer for the entire family, a lot of problems on violence inside the families because of not having access to education, social activities, etc. So this is my final reflection, that if one day we manage to move this public health mandate from stay at home to stay connected at home, we can make a huge difference with that. So with that, I thank you very much again for your time and for this opportunity.
Thank you, Dr. Marcelo. We have some Q&A now. Yeah? Do you want to say some words? Okay. Yes, so I wanted to ask the audience if someone has a question, please raise your hand. Oh, we see there.
Thank you very much for your excellent presentation. I just had a question on strategic partnerships. And so currently I find myself, I'm working on a project in a small island in the Caribbean, 150,000 people on a hospital development project, which is needed. They are also trying to establish digital health interventions, digitization of medical records, universal health coverage, smart hospital, and all these things. And so just would like to understand how granular PAHO gets in supporting these types of projects in the Caribbean specifically, and your thoughts on strategic partners like, Mount Sinai, the MAC, all these different consultant organizations that say they can support you in transforming your healthcare sector. Thank you.
Hey, yeah, I'll just, I'm gonna let, please, Dr. D'Agostino answer, but I was gonna invite you, Dr. Agarwal, to come to the stage because we hadn't questions for you either. So you can both take the seat in case you want. Please go ahead, Dr. Marcelo.
Yeah, well, thank you very much. I'm sure we will work together in this project because what you mentioned is exactly one project that we started with the countries. We will have a discussion in 3 or 4 weeks. We are having a roundtable and side event at Small Island Development State meeting that will take place in Antigua. And part of the discussion is exactly on how to have a multi-sectoral partnership for supporting small island development state on information systems and digital health. Answering your specific question, it's always depend on the type of request that we get from the countries or from the territories. Normally, we have a very strong connection with the Caribbean in particular. Everything that we do started in the Caribbean. 2016, we presented the situation and the initiative in a meeting that was co-organized with Jamaica, but with the participation of almost all the CMOs and permanent secretaries from the Caribbean countries, territories. The UK was there, France, the Netherlands also. Normally what we do is that we start with an assessment, a maturity assessment on the situation based on the tool that we have. And if we already did the assessment, what we do is we validate the assessment with them and we discuss with the country and local authorities who else should be part of the discussion. By definition, we have the IDB, but for example, IDB has no operation in some of the territories in the Caribbean, but the World Bank is working there. USAID is working there. We are having also conversation with CHISU and Mount Saint Hospital. I was with both of them in a conversation in Trinidad and Tobago recently. So with the assessment, what we do is to suggest a national roadmap. That all of that is led by PAHO, and then we discuss with the partner the different level of engagement. And then we have particular situations in where they already have individual conversations. For example, the group of I never know exactly how to say Mount Sinai. They are engaged making, for example, an assessment of the adoption of the DHIS2 platform in Guyana. Then they're also having conversations in St. Lucia. So then we have specific conversations with particular projects. But normally it's a standardized process that is being led by PAHO. I don't know if I answered your question. Okay, maybe I see you in Antigua in the meeting.
Yeah, hi, thank you. I'm actually from Jamaica, but I have a concern because like the electronic records in America, they're, more or less controlled by Epic. So if we're talking about like digital solutions that are like, cross-national boundaries and stuff, how can we stop like one entity from like monopolizing it basically and turn it into like more of a commercial venture rather than one for like, advancing health equity and whatnot?
Yes, well, this is a multi-million-dollar question that you have. Well, Jamaica is always a good example. We always learn from, in particular, Dr. Michelle Roof, who is leading the digital health and information system branch in the government there. It will be impossible to control that situation because that companies and countries are independent. But what we do as a potential way of controlling that is to reinforce the concept of international standards and the development at least of APIs for those companies to be able, for example, in the case of Jamaica, they just did a big investment for an EHR platform for all the country. But we were part of the definition of the request for proposal. So we control the way that the use of international standards. If we put also there, for example, in some other countries, we advise that the request of proposal for proprietary solutions should have APIs for the possibility of having connection with the ICD 11. So we try to put that as part of the request for proposal. And then we leave up to the country if they want to go with an open source solution or if they want to go with the proprietary solution. And in some cases, we can have a hybrid model because on core health data and indicators, there is a big movement now, in particular in the Caribbean. There is an agreement between CARPHA, the Caribbean Public Health Agency, and the University of Oslo for the implementation of the HIS2. So this is an open source solution. But for EHR, not only EPIC, there is other groups. I think there is a big group from Canada and other companies that are trying also to implement platforms. This is why we insist with the concept of standards. Because we cannot force any government to take any particular decision, but we show them that if they follow standards and if they follow some process, they will be able to avoid situations that happens in the past with proprietary solutions. I don't know if I answer your point. So.
I'll add that there is what a country can do depends also on what is their healthcare system structured as, and what is the role of the government. So if there is a large private sector, can the government have governance structures in place to set this standards ecosystem that the private sector can tap into? I think in the US, the governance came after the Epic, the scale that Epic or Cerner had already achieved. And so what that's now creating in the market is barriers for others to enter, but also barriers for other, so for example, if there are different AI applications that want to use the EHR, their barrier to entry is integration with Epic, which is a very heavy barrier for a startup to try to navigate. And so I think, in addition to what Marcelo already said about standards, I think also the role of having strong governance that precedes some of the development, I would say.
If I may to add something, there is another layer of complexity. It's not a simple solution. In federal countries like the US, Mexico, Brazil, Argentina, states are almost independent entities. So you need to have a very powerful negotiation role, including for the definition of standards for something very technical. For example, a country like Brazil with 6,000 municipalities that they can take their own decisions. We try to put this conversation at the level of different bodies. For example, they have the CONASEMS, who is a group who manages coordination with all municipalities. Then there is a group for the state called CONAS, but it's always part of a negotiation. So this is why it's so important also to have that context in mind. It's not just that the government can say, well, we mandate that situation. It's always about negotiation, and what we do is to try to show that if they follow international standards, like the red light, then you can select the company that you want to put your traffic system, but they know that they need to have red, green, and yellow. This is what we try to do.
Thank you. I have a question. The standards are a very good strategy to improve access and try to take everyone to the same table. In Dr. Agarwal's lesson, we learned about the dualism of even open sources being they are available to low-income countries, but they have technical assistance in the Northern Global, so it's difficult to integrate a few solutions and get assistance as well. I wanted to ask if you have some lessons on funding. So how do we overcome this, like global north, south, global dualism, and how to improve funding for digital interventions in low-income countries to avoid this type of bottleneck or challenge?
Well, thank you very much. It's in two ways, I think. One thing is that we have a lot of agencies that are supporting. We are very thankful, for example, for USAID has more than 15 years supporting with financial contributions in the Americas. In that case, it's through PAHO. In other situations, we have direct contributions from other institutions. For example, we always have an amazing support from the Spanish Agency for International Cooperation. Now we recently have a contribution through IDB of $5 million from the government of Japan, who want to support cross-border interoperability for vaccine certificates. We are always looking for funds that can be implemented at the country level and at the local level, and on the other side, we are also supporting countries to apply for grants that are available. Sometimes there is on one side a communication issue, because you have access here to all available information on Earth, very easy. If you have time, you find the information. Governments in big countries, they have teams. But when you go to small countries, you have only one person who is the epidemiologist, who is also the one who controls the pandemic, who is the one who needs to... We visit one country during the pandemic, and the epidemiologist was the one who received at the airport, who filled the form. Then the one we discussed the national strategy, and the last day they say, I need to make the test for you. He was the one making the PCR for going to the plane. So to that person, it's impossible to ask also to write a grant proposal. So this is part of the work that we do with countries, and we are so happy now with the generative AI tools, because we can contextualize and show them that they can at least prepare initial draft for resource mobilization. Together with that, we did an amazing partnership with the Inter-American Development Bank. So now the loans that small and big countries are having, big loans, $60, $100 million, they are based on the result of the maturity assessment developed together with PAHO. So at the level of a ministry or a secretary of health, is funds available. They don't care, the technical people, they don't care that these are funds that are coming through loans, through PAHO, through USAID. They have the funds to implement projects, but they need to have also some technical orientations. So we have a combination of funding models that we have for the countries.
I think we're at time, so I won't...
Yeah, so I was going to ask the last question. That's the question that we're going to pose to all panelists. So on a different type of resources, we've seen the shortage of workforce. How about people that are aiming at contribute in the digital health from the public health sphere? What type of advice, what advice would you give for us?
This is for us students. What type of advice would you give for us students?
Well, it's very difficult to give advice, no? Because I am very cautious to give advice, because everything depends on the context and personal situation, a lot of things. But from the technical point of view, if I would be in your shoes, I would try to have some kind of a personal strategy for continuous learning about digital something, but with the consideration of what exactly is what you need to know for your particular activity. Because one of the problems that I see today is that everybody wants to know everything on digital something. And I heard one person at one discussion that I was on MIT, and he mentioned the problem that we have today on AI is that everybody's saying too fast that they are understanding AI. But also I don't expect, for example,